Okay, we are live now. Subhadipta, you can start.
Okay, thank you very much. Good evening, everybody. I, on behalf of AY West Bengal, welcome you all in today's webinar on allergy and invasive fungal disease in COVID pandemic, the role of ENT surgeons, and the speakers are Professor Dr. Dwaipayan Mukherjee, Professor KPC Medical College, Kolkata, past secretary and trustee board member of AY West Bengal, and Dr. Snehasis Barman, honorary secretary AY West Bengal and senior consultant Chotushkon Uttarpara. There will be a panel discussion and the moderator will be Professor Dr. Amitabha Roychoudhury, Professor and Head, Vivekananda Institute of Medical Science, Kolkata, and the panelists are Dr. Arjun Dasgupta, Senior Consultant, CMRI, Dr. Ananda Brata Bose, Senior ENT Consultant from Siliguri, Dr. Diptanshu Mukherjee, Assistant Professor, Calcutta Medical College and Hospital, and Dr. Debabrata, Assistant Professor, Arjun Medical College and Hospital. We, for more than a year, are fighting with COVID pandemic and have already seen lots of complications which sometimes become fatal. But now, a new and dreaded complication have come in the name of mucormycosis. Patients with this complication are attending various ENT clinics throughout our state and on ENT, and our ENT colleagues are managing them successfully. I now invite Mr. Manoj Joshi of SANOFI to say a few words. SANOFI is providing technical support to our academic programs for last 1.5 years. Mr. Manoj Joshi, please.
Thank you so much, sir. Once again, a warm welcome to all eminent clinicians and respected doctors who are as either panelist, speaker, moderator, and all the eminent clinicians who have joined this scientific summit. Sir, just to repeat, my name is Manoj Joshi. I am working as a senior regional business manager taking care of Eastern Zone. I, along with my colleagues Manoj Day and Jona Vasu, welcome you all once again. Kindly give me just 1 minute, sir. I wish to salute your efforts on behalf of SANOFI in fighting the COVID-19 virus and saving the lives of the patients. We are completely aware of the valuable contribution you have extended to the society during these difficult times. And it is important for us, all of us rather, to maintain the social distancing. That's the reason these virtual meetings are gaining importance. Sir, as you are aware that we have been partnering with AY West Bengal and we have been getting support from you for all the scientific events, maximum scientific events, which are meant for the junior doctors and all the clinicians to have relevant take-home message and for the benefit of the patients. So SANOFI will continue its endeavor, sir, in spearheading, disseminating the scientific information with your help. And today's program, I did not dwell much upon that. It's a scientific summit, and I'm sure that all of you will enjoy the live interaction. So without further delay, I would request Dr. Subhajit sir to please help us by taking the proceedings ahead. Thank you so much.
Thank you, Mr. Joshi, for your kind speech. I just now invite our first speaker, Dr. Snehasis Barman, to deliver his lecture. Mr. Dr. Barman, please.
Thank you, Subhadipta. The second wave of COVID pandemic and the post-COVID complications like invasive fungal diseases have hit us strongly. And we, the ENT surgeons, are again in the front line providing our services and saving the lives. I, Dr. Snehasis Barman, Honorary Secretary of AY West Bengal, welcome you all to today's webinar organized by AY West Bengal on a very relevant topic, the role of ENT surgeons in the management of allergic rhinitis and invasive fungal diseases in the context of COVID pandemic. Allergic rhinitis is one of the most common diseases for which patients seek ENT consultation, and many confusions remain in the management of allergic rhinitis during this COVID pandemic. I will try to clarify some of the practical issues in my short presentation. We know that the cytokine storm is the deregulated or exaggerated cytokine and chemokine response to SARS-CoV-2 infection, resulting in excessive infiltration of inflammatory cells into lung, causing lung injury, and cytokine storm is the main factor responsible for the morbidity and mortality related to SARS-CoV-2 infection. In most of the moderate to severe SARS-CoV-2 patients, we find that there is systemic elevation of pro-inflammatory markers like interleukin 6 and tissue necrotic factor alpha. This rapid and exaggerated inflammatory response is directly responsible for lung injury and multi-organ failure. We know that mast cells play an important role in inflammation and allergies. Degranulation of mast cells releases histamine and proteases and leads to the release of pro-inflammatory cytokines such as interleukin 1, interleukin 6, and tissue necrotic factors. Here is the similarity in the pathogenesis of allergic rhinitis and cytokine storm. IgE-mediated degranulation of mast cells and release of pro-inflammatory cytokines occur in allergic rhinitis, and deregulated immune response to SARS-CoV-2 infection resulting in release of cytokines occur in case of cytokine storm. Here comes the role of medicines used in allergic rhinitis like antihistamines, leukotriene inhibitors, and intranasal steroids, which decrease the production of leukotriene, decrease the cytokine levels, and block airway inflammation and bronchoconstriction provoked by histamine released from mast cells. Antagonism to cysteine leukotriene receptor 1 by Montelukast attenuates the activation of nuclear factor and transcription factor P50P65, decreasing the downstream regulation gene expression and production of pro-inflammatory mediators and mitigating the cytokine storm syndrome. We know that systemic corticosteroids have specific role in the management of moderate to severe COVID pneumonitis. Also, we know that intranasal steroids do not reduce the immunity of the patient. In fact, they normalize the structure and function of the nasal mucosa and do not in vivo adversely affect the mucociliary clearance. It is now an established fact that use of intranasal corticosteroids is not contraindicated during COVID-19 infection. Timely and proper treatment of allergic rhinitis is very important during this COVID pandemic, as uncontrolled allergic immune response may increase the risk of viral dissemination. The European Forum for Research and Education in Allergy and Airway Disease, Euphoria, recommends that the treatment prescribed for allergic rhinitis, namely the oral antihistamines, leukotriene inhibitors, and intranasal steroids, should be started early and used regularly. Another point of confusion is that whether we should advise sublingual immunotherapy for allergic rhinitis and whether a patient with allergic rhinitis and asthma can take COVID vaccine. Sublingual immunotherapy for allergic rhinitis is recommended in ARIA guidelines and Euphoria guideline 2020. No major adverse reaction or anaphylactic shock is reported so far, and COVID pandemic is not a contraindication for sublingual immunotherapy as treatment of allergic rhinitis. People with underlying medical conditions such as allergic rhinitis and asthma can receive COVID-19 vaccine as long as they have not had an immediate or severe allergic reaction to the vaccine or any of its components. According to American College of Allergy, Asthma and Immunology, there is no evidence to indicate that taking low or moderate doses of inhaled corticosteroids for asthma weaken the immune system and impact the effectiveness of COVID vaccine. The Canadian Society of Allergy and Clinical Immunology recommends COVID vaccine for patients who are taking sublingual immunotherapy for allergic rhinitis or asthma without any special precaution. The take-home message is clear that allergy medications should not stop during COVID-19 infection or pandemic. Hope some confusions regarding management of allergic rhinitis in the context of COVID-19 pandemic are cleared. Thank you all for patient hearing. Now, all audiences who have joined us in the YouTube, please send your comments, share your comments and questions in the chat box. We will discuss your questions later on. Now I invite Dr. Dwaipayan Mukherjee for the next to discuss the next topic. Over to Dr. Dwaipayan Mukherjee.
Good evening, everybody. First of all, I'd like to thank the President and the Secretary of AY West Bengal and the entire Executive Committee for arranging this webinar on contemporary topic of surge of mucormycosis and the allergic rhinitis in the period of COVID-19 pandemic. Now, as we all know, there is sudden surge of mucormycosis in COVID-19 pandemic time, especially in the period of second wave. Now, the mucormycosis was there prior to the COVID era, but now we are facing this sudden surge of mucormycosis. So I think after completion of today's event, we will have a clear understanding regarding the probable causes of this sudden surge of mucormycosis and the role of ENT surgeons in this period of epidemic at the time of pandemic of COVID-19. Now, as we all know, mucormycosis is a fungal infection caused by a ubiquitous mold Mucormycetes found in the environment, in soil, and in decaying organic matter. That means the spore of mucormycosis is present in the environment, but it does not cause any harm to normal individual. It is one of the very important opportunistic mycosis in severely immunocompromised patients. That means if there is immunocompromised condition in those cases, it will act as an opportunistic infection. Now, heavy mold spore counts are usually present in the hospital air due to hot, humid conditions in our tropical climate and some unfavorable environmental condition in the hospital, like in the ICU or stagnation of the medical wastes in the hospital. So there is more chance of getting infection in the hospital environment than the outside. Now, whether mucormycosis is different in India? Yes, compared to the Western world, India data showed 170 times higher incidence. Uncontrolled diabetes is the major risk factor and overshadows all other risk factors. And rhinocerebral mucormycosis is the most common clinical type in India rather than the pulmonary one. And the spectrum of mucorales causing infection is very wide. Now, these are the three modes of transmission of the mucor. The most important one is inhalation. By inhalation, and the patient may get the rhino-orbitocerebral variety or the pulmonary variety of mucormycosis by ingestion, and we can found gastrointestinal mucormycosis, and by traumatic inoculation, we may found the cutaneous mucormycosis. Now, these are the predisposing factors for the mucor infection. Hyperglycemia, uncontrolled diabetes, and undiagnosed one are one of the very major risk factor for the mucor infection, along with diabetic ketoacidosis, uses of corticosteroids and anti-interleukin-6 directed strategies in COVID patients, cancer or post-transplant patients, and neutropenia on chemotherapy. Now, the question arises, India is the diabetes capital of the world. So diabetes were there prior to the COVID. Now, we used to use corticosteroid for other diseases also, like COPD, rheumatoid disease, and so on. So these factors were there prior to the COVID era. Now, what happened suddenly for last 3 to 4 months, so that we are having this sudden surge of mucor infection, and we were actually getting 100-150 cases across the country prior to the COVID time. But now we are having almost 12,000 to 14,000 cases in last 3 to 4 months in our country. Now, most likely, there are multiple factors. They are acting simultaneously in a specific point of time. There may be three-pronged assault. Number one, COVID-19. It may cause immune dysregulation, ciliary dysfunction, and thromboinflammation. Obviously, hyperglycemia, uncontrolled diabetes, and overuses of corticosteroids. That may ultimately leads to impairment in the neutrophil migration, ingestion, and phagoliposomal effusion. And it also exacerbates hyperglycemia. That means multiple factors, they are acting together. Most probably, this is the cause of this sudden surge of infection. Now, there is complex link between the COVID and diabetes. Around 7 to 21% of COVID-19 patients are having diabetes. This is high prevalence in India. COVID-19 virus can affect beta cell of the pancreas, resulting in metabolic derangement and diabetes. Virus may indirectly attack insulin production. Virus affect micro blood vessels, and beta cell could die, and also may attack or inflame other organ involved in glucose metabolism. Acute illness and inflammation causing symptoms of diabetes, stress-related hormones such as cortisol and adrenaline released in this time may also cause hyperglycemia. That means COVID infection per se is causing in hyperglycemic state in the body. Steroid also raises blood sugar, and new onset diabetes diagnosed first time at the time of COVID infection might not actually the newer one. Most likely it may be present and prior to the COVID infection. Now we come to the point of COVID-associated mucormycosis. I have told regarding the steroid and hyperglycemia. But COVID infection actually can alter the iron metabolism in severe COVID-19 infection, ultimately leads to free iron in the circulation. This excess amount of free iron in the body is actually creating a favorable environment and helps the growth of the fungal hyphae of the mucor. Another hallmark feature of COVID-19 infection is endothelialitis. Autopsies indicated widespread severe vascular endothelial injury in COVID-19 in then patients died of influenza A and H1N1. And now, the thing is that in normal individual, if they inhale the spores of mucormycosis, that can be easily neutralized entirely by the innate immunity. That means the phagocytic actions of the neutrophil and the macrophages. Now, overuse of steroid cause impairment of the neutrophil migration, ingestion, phagoliposomal fusion. That means there is problem with innate immunity if there is indiscriminate use of steroid. And this ultimately leads to a lack of killing of all these spores of the mucors. And it ultimately leads to germination to hyphae. It ultimately leads to germination to hyphae. It ultimately leads to germination to hyphae, and ultimately this hyperglycemia condition is also causing a favorable environment for the growth of this hyphae. Now, the thing is that there is endothelitis due to the COVID. And this endothelial adhesion and penetration are critical early step for mucormycosis. The acidemic state due to diabetic ketoacidosis and hyperglycemia induce the endothelial regulator receptor glucose regulator protein GRP78 plus mucorales receptor protein in homologs are creating perfect storm for increased adhesion and penetration of mucorales. Now, the thing is that means due to lack of innate immunity, due to overuse of the steroid, favorable condition created by the hyperglycemia and increased availability of the free iron in the body leads to germination and the formation of hyphae, and this hyphae may grow, and due to the endothelial damage by the COVID-19 infection is helpful for the endothelial adhesion and penetration of the vasculature and ultimately leads to final assault, that is the thrombosis of the microvasculature. So there are cascades of events: dysregulated innate immune response, ciliary dysfunction, cytokine storm, thromboinflammation, microvascular coagulation, and eventually immune exhaustion ultimately leads to favorable environment for mucor growth. And this mucor hyphae ultimately enter into the vasculature through the endothelial invasion, and that leads to thrombosis, and ultimately this thrombosis leads to all the damage to the surrounding soft tissue and bones. And after this invasion, there may be dissemination, and that dissemination ultimately leads to involvement of the surrounding structures like the sinuses, orbits, and the brain. So there will be cascade of events, but after the invasion of the vasculature, the situation can be changed in hours. So here lies the importance of early diagnosis. Presentation. These are the 5 types of presentation: rhino-orbitocerebral, pulmonary, gastrointestinal, cutaneous, and disseminated. 1. When and how to suspect COVID-associated mucormycosis? Most likely we are concerned about rhino-orbitocerebral mucormycosis. Initially, there is nasal blockage or congestion, nasal discharge, bloody or brown or black color, and local pain, facial pain or numbness, or unilateral swelling of the face. So these initial symptoms are very important because the nasal blockade and congestion, nasal discharge, and numbness of the face are the initial symptoms of mucormycosis. So if we can identify the disease at this point, and we can actually prevent all those mutilating surgeries. The other symptoms are headache, orbital pain, toothache, loosening of the maxillary teeth, jaw involvement, blurred or double vision with pain, paresthesia, fever, skin lesion, thrombosis, necrosis, eschar, and so on. These are all late presentations. Pulmonary mucormycosis, the symptoms are fever, cough, chest pain, pleural effusion, hemoptysis, worsening of the respiratory symptoms, and so on. So in those cases, we can actually do the lung CT scan. And it can be confused with the COVID-related shadows, or we can suspect mucormycosis in patients with thick-walled lung cavity, and we have to differentiate from pulmonary aspergillosis. Now we come to the diagnosis of the rhino-orbitocerebral mucormycosis. I am just telling in superficial manner because most likely we are having detailed discussion in the panel discussion. So from radiological point of view, MRI with contrast of the PNS and brain is very important. If the MRI is not available, we can go for CT scan. But the most important thing is endoscopic collection of the debrided tissue and biopsy. On microscopy or histopathology, KOH or LPCV staining, we can get non-septate or posiseptate ribbon-lined hyphae and branching at the 90-degree angulation. Mucor is difficult to routinely culture. Biopsy remains the mainstay of diagnosis, and the benefits of the procedure usually outweigh the risk. So these are the two pictures. I have received this picture from Dr. Shoma Dotto of Apollo Gleneagles Hospital. The lactophenol blue stain, and here these are the mucors, and here lies the hyphae of the mucors on KOH stain. And nasal endoscopy is very important and for the ENT surgeons and for the patients, because in slightest suspicion, it is always better to go for nasal endoscopy, because the earliest sign in nasal endoscopy is the discoloration, that is the whitish discoloration of the mucosa of the middle turbinate, mucosa of the nasal septum, and the inferior turbinate. Here we can see this blackish discoloration of the mucosa of the middle turbinate. We can identify this blackish discoloration quite easily, but the more significant thing is whitish discoloration, because earliest findings are whitish discoloration, and because there is lack of vascular supply to those areas. So by doing this nasal endoscopy, we can identify the mucor at the earliest point of time. So nasal endoscopy is very important and from the ENT surgeon's point of view. Now treatment team approach is required with infectious disease specialists, microbiologists, neurologists, ENT specialists, ophthalmologists, dentists, surgeons, and radiologists. This is also very important from medical legal point of view, because only single specialist cannot actually handle all the things. So we must incorporate all other colleagues from different specialty is to form a group to treat this type of disease. Three major modes of treatment: control of underlying disease, surgical debridement of the infected tissue, and specific antifungal therapy. ENT and surgical team should be consulted for debridement, and delay should be avoided. Surgery found to be an independent variable for favorable outcome in mucor patients. And another important thing is that when we are actually treating those patients, and clinical staging is very important. And because stage 1 means the involvement of the nasal cavity, stage 2 means involvement of the paranasal sinuses, stage 3 means involvement of the orbit, and stage 4 means involvement of the brain. So if we can identify the disease in the early stage, that means stage 1, then in many cases we can actually avoid all those mutilating surgeries. Liposomal amphotericin B is the choice of first line therapy for 3 to 6 weeks. Now, mucorales are not black fungi. We should not call the fungus related with their colors. Black fungi are different category of fungi having melanin in the cell wall. Mucormycosis is not contagious. It does not spread from one person to another, and no antifungal prophylaxis is usually helpful. Now, prevention is always better than the cure. Environmental cleanliness is of utmost importance to have no exposure to the decaying organic matters like breads, fruits, vegetables, soils, compost, etc. And mask is also very helpful to reduce exposure even after recovering from the COVID. We should control the hyperglycemia, glucose monitoring in COVID-19 patients requiring steroid therapy. Optimal steroid use, we should avoid giving steroid for the asymptomatic and mild cases, and optimal and selective use of antibiotics and antifungals are of immense help. We should not consider all the cases with blocked nose as cases of bacterial sinusitis, particularly in the post-COVID-19 period. During discharge of the patients, advice can be given about the early symptoms or signs of mucormycosis to the relatives. Simple tests like pupillary reaction, ocular motility, sinus tenderness, palatal examination should be a part of routine physical evaluation of COVID-19 patient at the time of post-COVID follow-up. Here lies some of the controversy. I will not go into the details, but there are some views that the overuse of zinc is one of the precipitating factor of these mucor infections. The mask, the soiling of the mask, industrial oxygen, new strain of COVID, steam inhalation, mucor-specific immune dysregulation by COVID-19 infection. These are all probable hypotheses, but at this point of time, we cannot say on definitive basis that these are the causes of this sudden rise. But I think at the end of the session, we can discuss a little bit about all these probable hypotheses. So in the summary, COVID-associated mucormycosis should be suspected in diabetic patients with severe COVID-19 infection. Steroids not be given indiscriminately. Good glycemic control while managing COVID-19 is essential. We should be very cautious when we are dealing with older age diabetic ICU admission and glucocorticoid therapy to the COVID-19 infected patients. Cost of treatment is a serious challenge in India, considering the number of patients cannot actually afford the therapy of liposomal amphotericin B. Thank you for patience hearing. So with this, I conclude my presentation. Now I will request Dr. Amitabha Roychoudhury to take over. He will moderate the session of role of ENT surgeons in this mucor infections, and the panelists are Dr. Arjun Dasgupta, Dr. Diptanshu Mukherjee, Dr. Ananda Bose, and Dr. Debabrata Das. Over to Dr. Amitabha Roychoudhury.
Thank you, Dwaipayan. At the outset, I would like to thank AY West Bengal for just 1 second. There is a little bit of problem here. Just 1 second, please. Just give me 1 second, please. There's something wrong.
We request our audiences to stay connected. There is little problem with the connectivity of Dr. Amitabha Roychoudhury. He will join us soon, and our program will continue. I request all the audiences to share your comments and questions in the chat box. The questions will be discussed at the end of the event.
Yes, Amitabha joined.
Yeah.
Yes, let me just share the screen. I'm deeply apologize for this glitch. Okay. Can you see my screen?
Yes, yes.
Thank you. I would, at the outset, I would thank AOI West Bengal Executive Body for organizing this and giving me an opportunity to be part of this webinar, and also very judiciously having selected our panelists today, because we have a mix of panelists where Dr. Arjun Dasgupta and Dr. Ananda Bose are very senior ENT practitioners from private and corporate setup, and Dr. Debabrata Das and Dr. Diptanshu Mukherjee are both are from a premium teaching hospital. So we have the flavor and experience from both the sides. So without wasting any time, Dr. Dwaipayan Mukherjee has given you a very comprehensive overview of mucormycosis. So what we plan to do today in the next 35 minutes or so to deal with the practical aspect that we find in our day-to-day practice, and also the challenges that we face and what should we do to overcome these challenges. And we would avoid any specific guidelines, specific references, because the time is very short. So I think this has been dealt with very thoroughly, but I just want to reiterate that angio invasion is the first stage of this disease, and ischemic necrosis because of the end arteritis obliterans is the final stage which causes the tissue necrosis. So if we catch them early, then we will be able to do justice to this patient. This has been highlighted as well, very well. Coming to symptoms and signs, I would just, if you go to the literature, you will really find that there's a huge list of signs and symptoms, and Dr. Mukherjee has also told us. I would start with Dr. Ananda Bose being the senior most, and I know that he has seen quite a few cases of this mucor, and therefore please tell us what has been your experience in terms of the presentation that as we as an ENT person get.
I've been seeing Mucor patients since last year. Unfortunately, initially the reference was from the eye surgeons, where the patient was presenting to them with frozen eye or blind eye, and the outcome of patients was bad because some of them had already spread to the cerebrum. So it becomes the complete spectrum of rhino-orbital cerebral mucormycosis. But of late, what I'm seeing is, because of all the media coverage, there are a lot of patients coming with milder symptoms, and I think it's very important. I've seen patients with just nasal blockage and facial pain and numbness. And in these patients, the nasal endoscopy has been absolutely normal, not even the whiteness or black eschar, and even a nasal smear in these cases have shown no KOH. And in the MRIs and MRI, there was a suggestion of sinus disease, possibly mucor, but not very foolproof as has been shown in most places. And I have operated on one such case where the mucosa on the nasal cavity was absolutely normal. I did a pre-lacrimal approach, went in, and the sinus mucosa, there was blackish mucosa, which I debrided extensively and sent it, and I was thinking that most probably it may not be mucor. And then the culture actually grew mucor. And I started the patient on posaconazole, which was the only thing available. And what I'm trying to see is that because of the awareness, we are getting patients early, And I think if we can catch them before they spread to the orbit, the outcome will be probably better. And our threshold for surgery should be very low.
Thank you. I'll go to Dr. Diptanshu, who is in a teaching hospital. What is your experience in terms of the presentation? Because he has seen extremes. And to tell you very frankly, I have also seen in the past pre-COVID era, whenever we got Mucor, we got it very late after a lot of treatment by here and there, ophthalmologist, ENT surgeon, general physician. Finally, it came to an institution. And so this was the thing. But today, what is the scene, Dr. Mukherjee?
Sir, what we are getting in our institution is we are getting the refer from three, the School of Tropical Medicine, Department of Medicine, and from the Regional Institute of Ophthalmology. All are refers. They are referring the patients. That patient is having orbital swelling with mild diminution in vision. And generally, directly, patients are not coming to our ENT OPD having the nasal stuffiness or only the nasal symptoms. So we are getting the all the referred patient from the other department
So already,
of suspicion of sir this. But in private practice, as I am also a private practitioner. In private practice, I have received some patient that they are coming in fear that sir, I was having is allergic problem, this thing, that thing, and is there any chance because I am feeling slightly numbness and there is nasal stuffiness and nasal discharge. But this amount of patients are very little in amount. Most of the patients are unaware of their nasal symptoms. They are thinking, sir, this is due to the COVID or maybe post-COVID syndrome, that nasal congestion, but that is not mucor. So they are waiting for the development of the eye symptom. That is the problem we are facing now.
okay, I'll go to Arjun Dasgupta because you work in a private and corporate hospital. It is expected people report to you earlier with their symptoms. Have you seen any patient in this post-COVID era with just simple nasal symptoms without having any eye symptoms? And
I am yet to get a positive case.
okay.
We are going on a biopsy spree right now, and we obviously panicked at the beginning, and because of the mucor, and the mucors that we are seeing is a different to the mucors that we have seen before. Working in a hospital which has got a like a transplant unit going on, or a very active cancer services where the chemotherapy goes on, we are not unknown to the aggressive fungal sinusitis or invasive fungal diseases. So we have seen it, and usually these cases by the diagnosis time, we got the diagnosis, we got a call in the middle of the night that they have found mucor, and we went there. It's already spread to cranium, and by the next day the patient is dead. With the post-COVID mucor, we are seeing the patient with a presentation of a month, 2 to 3 weeks. So we are seeing a completely different ball game, and probably it's in the future when people will learn more about it and talk about it, and then we will learn more. So again, my experience, like Diptanshu, is mostly referrals, and referrals from other colleagues and ophthalmologists and neurosurgeons and everything. But the people have thronged to our clinics as well because of the panic.
Yeah, as
And
Diptanshu said, yes.
people have panicked and thronged to our clinics, and we are doing nasal endoscopy. We are yet to find. I think we are seeing the first wave, so we are. Most of them are already confirmed visual loss or some other morbidity they have presented with.
Yeah. So these are some of the pictures that I wanted to share with the audience, people there who are attending. This blackish discoloration is a very strong sign, and obviously people do present with orbital swelling, diplopia, and all that, and also when it spreads to the palate. But we'll come to nasal endoscopy. I think I'll skip this video because incidentally Dr. Mukherjee also showed this video. I'll show you another video just for the benefit of some junior colleagues who have not seen a mucor. So you can see, as the moment you stick your endoscope, you will see this kind of a blackish discoloration of the turbinates, as opposed to we are used to see some blackish discoloration in patients with nasal mass and all that. So entire turbinate, as you can see, is blackish. As Dr. Mukherjee showed you that video, where you can see, I'll just play that video again. Again, it's a black turbinate, and also more importantly, devitalized tissue in the nasal cavity. In sinusitis, what will happen if you suck that thing, then you will normally get vitalized tissue and it bleeds. And this is an extreme case where you can see that the entire nasal cavity is full of, it's dried up completely. So the patient presents with discharge, and finally, eventually patient complains that there is bloody discharge, watery, I mean, brownish discharge, and finally no discharge, because it becomes like this. The entire ciliary function is gone and there is necrosis. So I'll come to Debabrata now. Uh, Obviously, so this is again, to summarize what they have said, is initially nasal discharge, patient profile is important, progressive pain, and everyone has said the numbness around nose and cheek should ring the first bell, and toothache is fine. And the moment you see blackish discoloration, I think all the panelists have suggested that should ring multiple bells in our mind, and immediately it's a matter of hours that we should start working on this patient. I'll come to, but we also need to differentiate between a simple sinusitis complication of a pre-septal orbital cellulitis. So patient profile is important, finding is important. Now, nasal endoscopy, Dr. Debabrata Das, when do you do nasal endoscopy? Because in your setup, the moment the patient comes to OPD, obviously, do you do the nasal endoscopy, and how do you do the sampling from the nose, and what microbiological test do you ask for? I'll go to all the panelists later.
Okay. So, sir, as my previous panelist has already been described, that we are still in a phase to have a patient with the nasal findings. Unfortunately, you are having all the patients with blindness and loss of PLPR, absolutely. So, as a routine endoscopy to detect, that has already shown by Dr. Mukherjee, that it's the blackish discoloration. Not only that blackish discoloration that you have mentioned, that the perilesional changes is also important. Whether that bleeds on suction or not, that is also important. So now I am coming to your question that that there is nothing new in performing the endoscopy in Mucor. That is the usual protocol.
So that's a must, you would say. Yeah,
it's a must. And as we all know, it's a disease which grows by necrosis, which necrotize the tissues. So most of the tissues are insensitive to pain. So you can easily take some biopsy from the insensitive tissues and send the tissues into divisions, into parts. One part in normal saline for the KOH stain and fungal culture, and one part is in formal saline for the histopathology. So this is the usual protocol that we follow. But the swabs and scrapings, we are very because as the yield of this swab and scrapings are a little lower, so we don't send swabs and scrapings. So we mainly send the tissues for the sampling purpose.
Okay. Any comment, Dr. Diptanshu, on this?
Yes, sir. So if
anything you'd like to add to what
yes,
you have
sir.
said?
If you say what is the investigation of choice, I will go for nasal endoscopy with first a swab, that to be taken under guidance of nasal endoscopy, and from the not only the necrotic region, also from the active region. Only necrotic tissue should not be taken from the active region. I do not go for the scraping. We take and swab as well as biopsy under local anesthesia, and we send in 3. What Devu has said 2, we send in 3 directly, 1 for KOH mounting and direct microscopy, 1 for culture, because our institution culture comes in 3 days. It takes time. And if any idea from KOH, because we are not having special stain like a Gomori stain at present in our institution. So they are saying KOH, we cannot identify the mucorale, but we can say there is something fungal in our setting. So we have to wait for the culture. So we are sending in 3, 1 for KOH, 1 for culture, and other for tissue biopsy for HP.
I'll just comment one thing and ask for opinion from Dr. Arjun Dasgupta on this, that there are issues have been raised regarding the contamination of swab as you take. I fully agree. Dr. Diptanshu has said that guided swab from deep part of the nasal cavity is helpful, but we should discourage, I think, because I have seen patients coming from ophthalmologists who have just taken a swab blindly from the nasal cavity, and it has, yielded nothing. So that is a very important point. But comment from Dr. Dasgupta, and then I'll come to Dr. Bose also regarding
Um,
the test, regarding the diagnosis establishment.
till now, we don't have any very strict protocol about Mucor diagnosis and treatment, but one of the central government has put out a protocol, and one of the best one has come from AIIMS Rishikesh. And we also had a word with one of the leading mycologists of the world, Onalok Chakraborty, who's in PGI, Chandigarh. Basically, they are saying against taking a swab from the nose because, as we all know, mucor is a normal nasal commensal. The people who we are talking in here, many of us have mucor in our nose. It's only when the mucor turns aggressive in a post-COVID, uncontrolled diabetic, unregulated steroid, then it turns invasive. And the invasion can only be proven by a biopsy. So just a nasal swab, though there is, there is a thought that the high colony count in a nasal swab will probably go towards mucor anyway. But the invasive mucormycosis can only be proven by a biopsy of a targeted area. And that is how it's said. And the KOH smear and stain still now is the mainstay of diagnosis. It gives you within an hour. It doesn't say exactly what it is, but in this environment, in a biopsy, so in a biopsy means the fungals are already inside the tissues. If there is non-septate, accepted hyphae, that means we are talking about mucor or some other very invasive fungal elements. And the next step will be like, we have a patient that despite doing a KOH and fungal stain and everything, they couldn't find anything. And then after 2 days, the biopsy picked it up. So we are still learning from it. So the time frame can be a few hours from a KOH stain to 12 hours for a fungal stain to about 24 to 48 hours for a histology to pick up fungus. Not the diagnosis, but
Thank you. Dr. Bose, do you have any experience on frozen section? Because sometimes it can save time in diagnosis. What is your opinion on that?
I think frozen section is not available everywhere, and
If it is
it's
available.
I don't have any exposure to frozen section.
Yeah.
I go by the KOH smear, and I send the specimen for culture, and if the culture comes positive, that's well and good. As far as the diagnosis is concerned, I think you have to speak to your microbiologist how comfortable they are in dealing with the tissues for KOH, because in the KOH, if you take a biopsy, it has to be crushed by a tissue crusher and then stained. And in some they have to dissolve it, and the dissolving those tissue takes time. So discuss with your microbiologist how they would like the specimen, because ultimately you need their opinion. And I think if you have a devitalized tissue, that's fine. But I want to see how many normal mucosa that Dr. Arjun is biopsying is showing mucor in the tissue. What my feeling is that
It's a very important
we
point.
cannot forget clinical suspicion. If we have a high risk patient of a COVID patient who is diabetic, who has received steroids, who's come with nasal symptoms and facial pain and numbness, if your MRI is suggestive of sinusitis, doesn't matter if your nasal endoscopy is normal, doesn't matter if your swabs are negative, you should go ahead.
Yeah, we are coming to that
If we catch
question.
them early, we are missing the boat.
Yeah, so I think I'd just like to share that we've had a case where we did a frozen and we got a very quick diagnosis of invasive fungal disease. If facility is available, this is good that you can immediately confidently go for extensive debridement and start toxic medications. But this is what Dr. Bose has suggested, that having a dialogue with the microbiologist, training the OT theater staff to prepare the sample for KOH smear, because otherwise many samples go, these theater sisters are very used to putting formalin in everything that comes out. So unless you train them, unless you tell them, and unless you warn the microbiologist, the sample may be lying up in a busy clinic for 6 hours, then the yield will be very low. It has to be tested immediately as it reaches the lab. Yes, Diptanshu.
Sir, in last case, we received that it was a case of candida. But after opening the, after seeing the MRI and what Arjun is saying, if little bit of suspicion, go for surgery. After opening the sinuses, we are seeing that typical findings of mucor.
Like
So
Ananda
there may
said,
be double
his case,
infection.
yeah.
There may be double infection, double fungal infection. Chance is low, but there may be.
Theoretically it is possible, but yes. So we are coming to the radiology, which is the next step, because the time is very short. We cannot go in details. So radiology, I'll just ask Dr. Diptanshu now, what is the role of CT scan? We'll talk about MRI in details because we all know. Do you do CT scan in your cases or not?
Yes, MRI is always not available in all setup, so it is available in our setup. So patients are coming with CT scan from outside. We are seeing that there are isodense mucosal thickening, and if there is any bone erosion, if this kind of thing, then we are giving that you should do MRI, specifically T1, T2, and DWI, which is available in our institution. So we are routinely doing MRI in our institution.
Okay, so the Debabrata, what is the what is your threshold on doing MRI? Do you ask for MRI in all cases? And message I want to give to the attendees: there are lots of juniors, lots of junior colleagues, and lots of doctors who practice in periphery also. Message that we want to give out from this webinar is that if you want to, if you suspect a mucor, what advice should you write in an MRI slip or a prescription, so that the MRI and CT does not have to be repeated when they go to a different institution, and early treatment can be started. Anyone can take this question, but Debabrata will probably answer this. What sort of MRI?
Yes, sir. So proper writing should be it T1 contrast, T2 fat suppression images along with diffusion weighted that have been mentioned, and don't forget to mention that angiogram. MR angiogram is also important to prognosticate the disease. You may find the patient is having the disease in the nose and close to the orbit, but at the same time, patient may have some infarct in the brain too. So while you operate the patient, you are overlooking the fact that there is a simultaneous infarction in the brain, and that may develop in later on. So the patient may blame, or patient party may blame you that even after starting the treatment, the patient develops the consequences like stroke or the loss of vision. So the ideal 4 sequences, that is T2 contrast, that is T1 contrast, fat suppression T2 sequences, along with DWI, diffusion weighted image, and angiogram should be the proper modalities of the imaging of MRI.
Any comments on MRI? Anybody? Actually, will not spend much time on radiology, but I think Dr. Debabrata has brought out a very vital point, that you should check the brain also and the vascular status.
If I may just add, I think takeoff is optional, but landing is mandatory. So if you're in the periphery, you have a job to do as well of diagnosing a patient of mucor quickly and referring the patient to a center which can deal with it secondarily. Because you can do a CT, and if you see a sinusitis, the history is suggestive, the findings in your nasal endoscopy is suggestive, and you know that you can't manage this patient at your setup, please refer the patient immediately on an urgent and emergency basis. Pick up the phone and talk to the person you're referring to, so that that patient can be treated early. Because not everybody will have the facilities to treat these patients. And if we amongst ourselves form a network and get these patients into OT quickly, then probably we'll be saving more vision and more lives.
This is the kind of sensitization we want to bring out from this webinar. Yes, Arjun.
The contrast MRI has got another function, which is again coming up from all the national webinars of mycosis that I have watched and being a part of. Is you don't have to, because we are again You have to be very aggressive in the surgery, though we are not in the part of the surgery. But you have to be conservative as well. You can't just take everything out. And the contrast, the whole idea is the area of the vitalized tissues which have taken up the contrast are there, are vitalized, and obviously amphotericin B will reach there as well. So there is no point in excising those tissues which are highlighted by the contrast. So it has taken up the contrast, amphotericin B is going to reach there, leave them alone. Take the devitalized tissue away.
Yeah, just to show you that this is a same patient T1 image where you can see there is extensive disease of the sinuses, including the nasal cavity. In T2, you can again see uh, highlighted because these are highlighted areas of disease, but these are non-highlighted. And when you do a T1 contrast, you can see non-enhancement as you have seen. So this suggests that this is non-vitalized tissue and this is vitalized tissue probably. So when you do the surgery, we'll talk about surgery. So this MRI will give us a guidance about the staging and the extent of the disease. So I think this has been all talked about this. Only one point I was going to tell you what Debabrata suggested is that MRI in a contrast, it suggests that this is the cavernous sinus on one side. In a same patient, you see that the cavernous sinus is involved, but the carotids are normal. These are the two spots. But subsequent MRI in the same patient shows that the carotids is also involved. So there is an issue of developing carotid aneurysm and those kind of things. So that is sequential MRI has also role. Management philosophy will now. There are lots of guidelines coming in the literature. I would go to the panelists now gradually and ask you that what importance are you, Diptanshu, you want to say something on the previous?
Yes, sir. So one thing in MRI, if we see the MRI, we can differentiate between the early disease and advanced disease. And one thing is that the black turbinate sign, the MRI finding.
Yeah.
I want to
I think this is what we
the MRI ischemic turbinate in MRI finding. It is not what I think in nasal endoscopy.
No, not at all. Yeah, this is what the scan that I was showing you. This is showing this one.
Yes, sir. And earliest kind of the orbital involvement is in the middle rectus. There may be thickening in the middle rectus. It is the earliest sign. If anybody ENT specialist see the MRI, they can see the middle rectus thickening. They should think of that mucor maybe in early stage, so they can refer the patient. This type of patient, but those patients who are already involvement of the brain. So I think that type of patient is high mortality. If you go for surgery, it's impractical and there will be high mortality.
Absolutely. Point well taken. Now, this is a very old staging which was in the literature. We used to follow this staging until, last year or year before last year, 1991, as early as that. Stage 1 is nose and sinuses, stage 2 is orbit, stage 3 is cerebral. Now, people have come with a newer stage. This has been published in Indian Journal of Ophthalmology, which is many people are now following this. 1 is nasal mucosa, 2 is paranasal sinus, 3, like Dr. Mukherjee said, 3 orbit, 4 CNS. The point is, do you go by staging to decide your treatment protocol, or do you individualize the patient? Dr. Ananda Bose, please.
I don't go by staging. I mean, by and large, what we're dealing is, I think the only two things that are important here is whether it's spread to the brain or not. If it is spread to the brain, then whatever it's you, the mortality is very high. And for the other bit, I am interested, if you look at the surgical spectrum, you almost do the same surgery for everybody. Your axis is the same for almost everybody, except where your skin is involved or your palate is involved. The rest of the axis is all medial maxillectomy. So I don't think staging is really adding to it. And the treatment protocol will be the same for all these. For documentation and for records, it's okay. But as far as management is concerned, my own main concern is whether it's spread to the brain or not.
Okay, I think Dr. Mukherjee has already said the management theme: glycemic control, immunosuppression correction, amphotericin B debridement. We probably will not be any of the panelists who really goes by staging, or individualize the treatment. Otherwise, we'll go to the next. Uh, Now, amphotericin B, obviously, there is no doubt and no debate about that. I will go with some other issues. There is no point discussing the manner of infusion, how it is given and all that. This is standard in the textbook. If you get a patient, that's very standard. How long you will do the treatment? I will just ask Dr. Arjun now. If you see a patient, you start ampho-B, you have done debridement. What is your, because there's no hard and fast dictum in any literature.
The CDC guide, not the Lancet infectious disease protocol says that you have to give amphotericin B injection for 3 to 4 weeks. The AIMS Rishikesh protocol is you have to give the amphotericin B for 2 to 3 weeks and then oral posaconazole for another 6 weeks. Lancet said that after that, oral posaconazole should be given for 6 months. We are giving as whatever we are getting, as we are getting. If we are not getting, we are not giving. If we get amphotericin B lipid, we are giving amphotericin B lipid. If we are giving liposomal amphotericin B, we are giving liposomal amphotericin B. If you are getting the plain amphotericin, we are giving plain amphotericin B. If you are not getting anything, there are days the patient goes without any injection. So that's the situation on the ground.
You seem to be sounding like beggars cannot be choosers.
Absolutely.
Okay. So we are not going to discuss that, but depending on, there are some issues. And also,
can I just make another point? It's very good to have the microbiologist on the board. In my very short experience, the colony count does matter. You know, the cases of Mucor that I have, that you have to really search for 2 days and you get 2 Mucor hyphae after searching for 2 days, will probably do well with posaconazole as well. But if you give amphotericin B, and then you can stop the treatment at some point. But with a high colony count of Mucor, you probably have to go very aggressive and try to stick to the real regime as possible. I am talking about war scenario. I mean, where there is paucity of everything. Otherwise, the ideal scenario is everybody gets amphotericin B.
So as we go here, I will just we had a question later in the series that if you start with amphotericin B of one patient and then obviously you are not getting the thing, what I gather from Arjun is that we have to do whatever we get. Mainly posaconazole is now available, at least in our state, and I think all of the panelists will agree that we will be happy to convert it to posaconazole. As Arjun said, if there's one more question, I have had this problem in our institute, though I am not actively practicing at this point of my juncture. The point is that 3 days after debridement, it was there, and then 2 days it was not there. Then again, M4 became. Would you then revert back to M4, or would you continue both?
Yes.
Question to Diptanshu.
Sir, what I want to say that we are facing a main problem in getting liposomal amphotericin.
Yeah.
There are lots of amphotericin B deoxycholate is available.
Available.
But liposomal is not available. And what the problem practically we are facing, that when you start the infusion of deoxycholate, there may be rigor, there may be fever, and there may be intolerable fever like 104 Fahrenheit, 105 Fahrenheit, and it is discontinuing patient is. So there is severe hypokalemia, 1.3 potassium count, and our PDT are giving the amphotericin B deoxycholate whole day on 12 hours in a black type of wrapping.
I know. So that is a challenge.
That is a challenge to give amphotericin B, because posaconazole is not available in medical college region or any region in this side. Ojunda in that region may be available, but IV posaconazole is not available in this region.
No, oral.
That is deoxycholate at present.
No, the question is oral is available, and if M4 is not available, Ananda, what is your take? Because you have also had patients like that. 3 days you gave M4 and then no, it was not available.
No, the one I started, the initial patients that I had operated, they were all those ones with which had gone to the orbit, and in those patients we did get amphotericin B. But recently, the patient I operated, the very early one that I talked about, there I have used posaconazole. And my philosophy now is that, posaconazole is also very expensive. I mean, you know that
Yeah,
syrup
six,
itself
seven
costs
thousand
about
per tablet.
26,000, and it probably lasts for, it is 105 ml, so about 7.5 ml, so it lasts for about a couple of weeks maybe. And then the tablets are about a 5,000 plus, so it's a huge cost on the patient. But I have used posaconazole. I've made sure that it's available. So I haven't had to discontinue treatment, but I would love to have the liposomal amphotericin.
So I think without wasting, because we do not have much time to carry on this, but we all of us agree that we would love to have a 4 to 6 weeks of M4B, depending on what. If it is not available, posaconazole. If that is not available, we can't help it. We have to still keep on doing the surgical debridement. Now, coming to surgery quickly, open versus endoscopic, and how much and how far we would do. We have already discussed one point, that MRI will guide us how much to do, how far to do. I think I'll skip this now. I had some. So this is a kind of scheme that I have put down for all of you to read and then comment your individual opinion. I think if nose sinuses without any much bone destruction beyond the confines of nose sinus surgery, just a endoscopic sinus surgery with medial maxillectomy. If maxilla or zygoma is involved, there's blackish discoloration already from outside, I think extended outside surgery has to be done. If extensive orbit involvement, obviously orbital debridement or exenteration, we'll discuss that. And if the skull base or anterior orbit involvement is there, then again infratemporal fossa, we can go endoscopically. We can go a lot into, just like a JNA, we'll do the surgery. It is almost like a JNA surgery. And obviously, intracranial extradural, that is a debatable. We are not going into that. So I'll firstly come to Debabrata. What has been your experience and what is your take, how you decide?
So, sir,
Is
in this
endoscopic
era,
approach your first choice?
yes, endoscopic approach is the first choice, no doubt about that. If the disease has not involved the eyelids, not involved the lips, not involved the palate, not involved the skin, if the disease has involved the orbit to a significant amount, we can clear it endoscopically by pre-lacrimal approach that Dr. Bose has mentioned.
Absolutely.
So we should, as it's a morbid disease, we do know that and the patients, those are also already having visual loss. So we can do manage those patients by doing orbital debridement, even if needed repeatedly, by following up the disease parameters in post-op follow-ups. But the patient having already a vision loss, forming a total maxillectomy with total exenteration, I think this is practically not rational. Involvement of the maxilla, involvement of the palate, yes, you can perform maxillectomy, but if there is vision loss and there is orbital involvement, please clear it endoscopically if the technicalities is there.
Every case is individualized. I think I got your point. We'll go to Dr. Dasgupta. If you can sum up very quickly, we want opinion on all four.
I'm seeing this chart, and I'm that I'm already a strong believer of endoscopic surgery, and without the zygoma involvement, I think most of them can be done endoscopically. Even the palatal bone can be slowly teased out of and keeping the mucosa intact. So all the WhatsApp messages that we are getting of horrible surgeries taking half of the face away, I don't think unless there is a skin involvement, none of them is necessary.
Absolutely.
And even if there is a skin involvement, you just do a local debridement, and that can be closed with a local flap, because the skin of the face is a lot of lax structure. And orbital exenteration is a hugely debatable topic.
We are not going into that today because we cannot finish the webinar then.
Absolutely. Let's not go in there. And if there is intracranial extension, get the neurosurgeon involved. It's not in our hand anymore.
Okay. So before I go to Dr. Ananda Bose, I would again reiterate what Dr. Debabrata earlier said, that essentially the MRI shows us, and also we are going to debride all the tissue which is dead and devitalized, because the antifungal will reach the vitalized tissue only. So reduce the fungal load. We endoscopic or external, no surgery is cure to this disease. Just reducing the fungal load and restricting the spread, we are doing the surgery. So that should be, I fully agree with now Dr. Bose. Again, quickly over a minute, if you can sum up your
I think
approach.
the principles of surgery is the most important thing. Your approach, whether it's endoscopic or external, the key areas are the turbinates, the ethmoids, the sphenopalatine area, the pterygopalatine fossa, the septum. These are the key areas. If you can address it endoscopically or external, it's up to you. But I would be very, very, I should say, I should have a very, I should try and preserve the palate as far as possible. Taking huge amounts of palate out, it's a huge morbidity to the patient. So just don't take it out just because you're doing an external approach, you have to take the palate out. You can even do an external approach, use the microscope, extensively remove the disease as you are doing endoscopically, and at least preserve the palate. And this patient, if it lives, it's going to live with less morbidity. So I think the key areas and the principles of surgery have to be stuck to. If the orbit is involved, you can orbit take it out inside, outside, it's up to you. But follow the principles of surgery. The key areas are the sphenopalatine area, the maxillary sinus, the pterygopalatine fossa, and these are, and the septum, and these are the key areas that you have to address no matter which way you're operating.
Very well said. Dr. Diptanshu, your
Same,
threshold
sir.
on.
What I think that by seeing the MRI, the surgeon who will operate, he will be the best person to think that he will go open or he will go endoscopical. If there is involvement of that, what Ananda has said, that pterygopalatine fossa, this region, that I am not sure that I will open up that area, then I will go in open approach. But if I am sure that endoscopically I can debride all the tissue, all the necrotic tissue, that is my main target. All the necrotic tissue, then but orbital decompression endoscopically we have not done in such a manner. Orbital exenteration was done by the eye people in 2 cases. In our total 7 cases, 2 cases was done orbital exenteration. But endoscopic orbital debridement in such a manner, what the video is shown by Dr. Satish Jain, it was not done in such a manner.
Yeah, so I think there are papers published even well before the COVID era that you can do and partial orbital debridement, even by Dr. This is a paper by Dr. Bradu, which is in Indian context. So you can do that. So I think most of all the panelists do agree. Yes, Arjun.
There is a paper from Arvind Eye Hospital in Chennai.
Yeah.
They are doing endoscopic medial mesial orbital decompression, debridement, and and a nasal amphotericin B wash. And till now, they have done about more than 100 cases, and they didn't have to do a single orbital exenteration. That's what they're claiming.
I think many of the ophthalmologists also tells me, and we have seen in the literature, that intraorbital or retroorbital amphotericin B injection is a very novel approach, very good approach, which is avoiding a lot of eyes being sacrificed. That is, though this is not our subject. So I think all
1 minute. And intraorbital amphotericin B, one patient is also receiving, but till day after receiving 3 or 4 days, no such improvement in vision noted in our case.
No, vision.
Vision is
just
separate, but you may save the eye.
Yes.
You can do medial orbital decompression and remove the necrotic tissue. The eye may not be functional, but cosmetically you may save the eye.
Oh, save the eye.
That is the principle.
I think that the term being used is orbital clearance, not
exactly.
orbital exenteration.
Yeah.
So I think if it's a blind eye, you can play around and do what you want if you think you can do it. But I think this amphotericin B injection is where you're doing a decompression. The orbit has not been extensively involved. I'm sure having if a patient has got a vision in that eye, trying to do an orbital clearance on that patient requires lots of cuts. I don't have it. In those sort of situations, amphotericin B injection is fine. But with a patient with an intact vision, and you're trying to do overtly clearance, I think that is not my cup of tea.
No, that is not, no, that's not practiced anyway. So to summarize the surgical issue, we all agree, all the panelists today here, is that endoscopic approach, being an ENT surgeon, is our choice of approach. But depending on your threshold of training, your threshold of armamentarium that you have, you may decide on open approach. But very mutilating surgery is not probably indicated, not probably the right thing to do, just because surgery is not curative. This is not cancer that you will, radically cut all the tissues and reconstruct. You cannot. This is the different thing. Surgery aids to the treatment of antifungal. Arjun, you want to add something?
Two of my patients has surprised everybody and started having finger counting vision come back, which was, there was no demonstrable perception of light. PL was absent. So we are saying we don't know about this disease much. We don't know about this disease really well, this post-COVID mucormycosis. So let's play a conservative game and let's see what turns out.
Absolutely. And I had this sets of questions. This has been already answered during the course of discussion, all the three questions which we had here. Follow-up. What is your plan for follow-up in these patients? This is the plan schema that I have put down. Anything that you would like to add, which I have missed? Because we do not have much time. We have to wind up now. President will gradually start.
Perfect. This is
okay.
Perfect.
So follow-up is important. Now surveillance. This is the last part of our web question today. How should we plan monitoring our post high risk patient in post COVID, and which post COVID patients should be kept under surveillance? And we also have heard about post COVID clinics coming up in many hospitals now to deal with very multiple complications that the patients are having. Going to Diptanshu, who is in a government setup. Please be very quick, because otherwise our president will kill me now. I'm overshooting the time. I'll finish within 2-3 minutes, sir.
So high risk patients are the patients who have already poor glycemic control, or those patients are diabetic. Then we should have to control the main thing is the diabetes. Diabetes increase blood sugar level. We have to make it normal. Then, and along with we have to do nasal endoscopy. And so how should we plan to monitoring high risk patient?
I mean, what I am saying is that when you discharge a patient, you know which are high risk patients. So when you discharge from COVID ward, there should be a universal protocol that patient should be warned about this additional leaflet, which we can do from even from our association. We can do something. Is my proposal that give an additional leaflet that these are the warning signs for you. You should consult an ENT surgeon straight away if you have this. So this is something that can be done from our side. From the association side also, we can sensitize all the hospitals. Dr. Ananda Bose.
I think there are three issues here. One is monitoring the disease progression by doing a CRP, which is cheap. Second thing is medical complications from the antifungal therapy, that has to be monitored. And third is monitoring the cavity and seeing if there are more dead tissues and debriding it in the clinic. So I think these are the three things, and you manage it according to how the patient can come and according to the suitability in the clinic.
That was follow-up of the Mucor patient, but we were talking now about the COVID, how we can get the patients to reach us early. That is the thing that we should do, because it is we have a lot of member in AY West Bengal, and if we sensitize ourselves and our friends and colleagues of general physicians and ophthalmologists, because in many cases I have got patients of Mucor in the past 15 years who have been treated for 15 days here and there for various reasons, including a proptosis, treated as cellulitis, IV steroid. So this has happened, and this do happen. But today we are more aware, because it's all in the air, all in the media, all in the webinars. We are more aware, but we must be a little bit more aware and sensitize our people. Any comment on this?
I will just one thing. Sorry, can I, Ananda, with your permission? Okay. I think one of the comments, the opening comments, I just want to contradict that a little bit. as we now have two set protocols, what is the central government protocol and what is the AIMS protocol? So both of them has very categorically said that do not treat post-COVID sinusitis as a normal post-COVID scenario.
Absolutely.
All post-COVID sinusitis should have a nasal endoscope. We have our boys and girls in the villages and districts. They all have nasal endoscope, and it's very easy for us to surveil for that. And that should be the number one, that do not, all the post-COVIDs have some degree of nasal symptom. Do not assume that they are sinusitis only. Please do a surveillance, at least a nasal endoscopy. If in doubt, serial nasal endoscopy once a week for some time.
Absolutely. So this is the team. We have already talked about teamwork. What do we need to do? Again, this is what we have discussed. I'll just finish it off now. Microbiologists needs to be sensitized, because unless they are prepared, they are sensitized, they will not be able to diagnose between contamination and invasion disease, clinical pathologic disease and contaminated disease. I've spoken to some microbiologists. It's not a big, it's very easy issue. And obviously, we need to ensure medicine availability and reporting. Legally, we are bound to report all cases because this is a notifiable disease in our state. So that message also should go to all the people who are attending. Because of paucity of time, I would like to conclude saying that we are fighting an unknown disease, COVID, fine, but mucormycosis is a known disease. We know how to treat it. So only we should have our antenna very high, because we need to diagnose them early, and if it's a nasal and sinus disease, we should be able to cure them, provided we get a stock of medicine. Diptanshu, you
Just
have
I
to
want to add, the Arjun has said in periphery, all have to do, we have to do nasal endoscopy in post-COVID patients. But before that, we have to do a RT-PCR to see the patient is negative or not.
No, I'm talking about post-COVID. Post-COVID sinusitis.
But Arjun, there are patients in the COVID ward, they are sending refer a total case of mucormycosis with orbital involvement 8 days in COVID. We are waiting, yes. But we have, yes. In those patients, what is the protocol? If the patient is positive,
the patients which are coming to us from COVID ward, we are taking all the precaution and doing nasal endoscopy in the theater. We have bunching them up 3 to 4 at a time. We are taking them to the special COVID designated, because we are doing COVID tracheostomies, COVID surgeries. We are doing COVID surgeries throughout the last 1 year. I have done. I think tracheostomy is far more dangerous than doing a nasal endoscopy. So we are getting them there. We are prepping up for proper PPE and things.
Is the mortality rate is high in COVID surgery of mucormycosis than the post-COVID surgery?
Sorry, I didn't understand you.
I didn't.
Sorry, I বুঝলাম না ঠিক আরেকবার বল
মানে I am saying a patient with COVID positive or you are doing a surgery for mucormycosis or with orbital examination endoscopically. The mortality of this patient will be higher than the post-COVID patient. Mortality, chance of mortality.
If a patient has COVID,
because of high anesthetic risk and high recovery convalescence risk, I agree. But you still have to treat them.
You have to still do it. I mean, you
but
can do
I
I
fully agree with Diptanshu that what is possible in your hospital, Arjun, may not be possible in a standalone clinic of a, somewhere in Raiganj and somewhere in Balurghat who is doing a standalone clinic, suspected COVID, immediate. So there are issues, but then we have to sensitize.
What I'm trying to
say at least if I cannot scope the patient, I refer it to a center where the scopies are being done if I suspect, so that there is no delay. Every hour in this disease is important. This is one message should go to all general practitioners, ophthalmologists and ENT surgeons at large. I think we'll conclude here, because we have it has been a wonderful panel, because of obviously we had to cover a lot of things. We could not touch upon everything, but some consensus has been message has gone out of this panel, I'm sure. And thank you very much all the panelists for being so so kind to be able to attend. And thank you, AY West Bengal, and especially SANOFI for supporting this. I would unshare my screen. Thank you very much, President sir.
So, thank you, Dr. Amitabha Roychoudhury, for wonderful panel and all the panelists. So, we are having lots of questions from the audience. So, I think, Snehasis, are you there?
Yes, I'm here.
Yeah.
So,
first question is directed to you. So, that has there been any change in the incidence or presentation of allergic rhinitis, given the fact that wearing mask could reduce the inhaled allergen load?
Actually, in most of the cases, the allergens are indoor allergens in cases of allergic rhinitis, and they are specific allergens. So there is not much difference in the incidence. There may be reduction in the cases for external environmental allergens in some cases.
So, what is the opinion of other panelists? Because this is commonly asked questions in different forum. As because most of the common people, they are basically inside the home or work from home environment, and wearing mask when they are getting out from the home. So maybe there is possibility of reduced incidence of allergic rhinitis, but in other allergic rhinitis or allergic clinic, we actually didn't found there is less number of patients. So most likely the patients were suffering from the perennial allergic rhinitis as because they were spending more time in the indoor environment and exposing themselves for the more time towards the indoor allergens. Dr. Ananda Bose?
I don't
Please
think I need
unmute
to add
yourself.
anything more. As far as I'm concerned, I think most patients can't get to us because of the lockdown and because of lack of transport. So giving an exact picture whether there's been any difference or not would be different. But as Snehasis and you alluded to, it's what you're allergic to. If you're allergic to indoor allergens, then your symptoms are going to be the same. And if it's external pollutants, then maybe you'd be suffering less. So it depends upon what allergen you're sensitive to. And I think it will be a very difficult question to answer exactly whether it is affected or not, because we can't see all the patients anyway. And you're lucky that in your allergy clinic, you're not seeing any difference. In my clinic, I have definitely seen that I hardly do, my ENT practice is probably 20 or 30% of what it used to be.
Okay, so Dr. Debashish Guho informed that researchers at IIT Hyderabad have developed oral tablets of amphotericin B. So most likely, if it will be approved by the drug controller authority and if it is available in the market, I think that will be good for all of us. And how many cases of Mucor mycosis so far diagnosed and treated in West Bengal? I think Dr. Arjun Dasgupta or Dr. Diptanshu, you people can answer it.
Arjun, have a fair idea.
I think frankly, we don't have any idea. The Chief Minister conference a couple of weeks ago said that there are 20 reported cases, which we are not aware of. I think just an intelligent guesswork, it is probably reached a few hundred by this time. But only the government has this data, and till now it hasn't been shared.
What Arjun, what I gather, from talking to people who are in our community, I think it has not gone beyond 100. It's not that high.
Most likely around 100 odd cases right now we are having.
This is what I think. Yeah.
Cases.
Yeah.
And I think in the panel we are treating about 100 patients in here.
No, I think it is not as bad as people are reporting from other parts.
Yeah.
Bengal, I don't think it's as bad as other words. People are operating 5 or 7 cases every day for Mucor. I don't see that happening.
But if you,
in my practice.
Ananda, if you look at the peak we had in West Bengal, And if you wait for
Yes.
6 weeks, then actually we'll get the picture.
Yes,
So
sir.
Maharashtra and Gujarat had the maximum number, but they had the peak much earlier than us. So maybe
But
the
Dr.
actual storm
I
is
think
coming.
your point of the
At least
association
we are
reaching out to
prepared.
its
So that's the
members
good
with a
news.
leaflet of saying what is high risk cases, and if you can't treat it, please diagnose and send it to people
Absolutely.
you can. It should be a very strong message from our association so that we are prepared before it goes through the roof.
Now, I just want to share another point, Dr. Amitabha Roychoudhury. You see, even in the pre-COVID era also, in our practicing time, we used to see lots of cases from the Nagpur, Pune, Rajasthan, or
Absolutely.
Gujarat, from
Absolutely.
that area. We actually
Some,
didn't see that
not
much
so
of
many.
cases in West Bengal. So most likely there are some environmental factors also.
Yeah,
So
absolutely.
Absolutely.
mucors are not so predominant in our region.
Fully
Probably
agree.
the
Fully
soil.
agree.
Fully
Like
agree.
when we were training
Even
in
in the
PGI,
first
we used
wave.
to see a lot of fungal disease, which whereas when in West Bengal, I had hardly seen any fungal disease. So there
In
are
the
some
first
regional
wave, they
differences,
were
whether it's
reporting mucus.
because of the agricultural practice of the
Absolutely.
the soil, how they prepare it, and all that. So
Cotton cultivation.
Yeah, we having a little bit of referral type of practice. I think 1 or 2 mucor per year is the maximum that we've had in the last few years, pre-COVID. That's what I'm saying. And and our referral comes not only from West Bengal, sometimes from the Northeast and Bihar and Jharkhand and Odisha. So considering that it is not very high in this eastern region as a whole.
But nowadays, sir, we are getting every day 1 or 2
No,
referrals.
now obviously we know.
I mean,
So that's what I'm saying.
PGI Chandigarh
Our
was saying that they are getting about 20 cases per day. So we haven't gone there. And even in the fast wave, the Maharashtra and Jaipur were reporting mucor. And I remember me, Chiro and Mohan was saying that why are we not seeing them in here? This was the first wave, and they were getting a lot of mucor at that time.
So another
next
question,
question.
as immune exhaustion is the cause of invasive mucormycosis, are these patients at higher risk for or contacting other hospital acquired infection, and do they need reverse isolation? And also, how the fast wave could escape mucormycosis? This is open to all.
I think I just mentioned the fast wave.
Yeah,
I think
so most likely actually the noise level related with mucor, the basic reason behind that, most likely we are having very severe disease and the rate of mortality is so high, around 50 to 80%. So we are actually in the situation of high noise level for the mucors, but most likely there are other opportunistic infections, and in fact some of the reported cases we are having mixed infection with mucor and aspergillosis. So most likely the other patients, they are suffering from other opportunistic infection, but the noise level for mucor is so high because the mortality rate is very high.
The
And another case,
cytomegalovirus.
how the fast wave could escape mucormycosis, as Dr. Arjun Dasgupta said, most likely we were having mucormycosis in the fast wave also. But as because the number was less for the total cases, so most likely we were having very limited number of mucors at that time.
one more point. This is just my thought that severity of disease in not percentage, people who get severe, who become severe, say 5% of the total affected people are getting more severe in the second wave. So the biochemical changes, the angiogenesis and all those things probably are in more severe form with this new strain, or if it's a new strain at all, we do not know. Then that may be also an additional factor which is causing the insulin mechanism, insulin metabolism to some, because there are lots of theories coming up on that also, and that is why
Can I add a point? The famous rescue study done by UK and EU, which kind of touted the steroid as one of the massive beneficial drug in combating the cytokine storm was formulated from around September, October, that time. So that was implemented, and that led to a widespread abuse. And steroid is not that much abused in West Bengal. Like when speaking to the colleagues everywhere, the WhatsApp messages, they started giving steroid from the day 1 rather than the day 7 or 8 when the hypoxia occurs. So massive not getting the steroid in by proper dosage and non-indicated is one of the main factors probably why we are seeing the surge of Mucor in the second phase. At least that's what the papers that are coming out are pointing out to.
No, I think this is very important facts, because at least in the first wave, maximum number of patients, at least in West Bengal, were supervised. But in the second wave, we were actually having more number of patients in a specific point of time. So maybe some cases were not supervised and were getting all this indiscriminate use of the steroid or other antibiotics or antifungals. And another important thing is the COVID-19 infection per se may cause some inadequate control of the diabetes, causing hyperglycemic state in the body. So if we were treating those patients in home with teleconsultation and by phone call, so we were actually not judging the exact glycemic status of those patients, and we were actually prescribing those steroids or other things. And most likely this abuse is limited in West Bengal, because all those webinars and scientific platforms and all those programs, not only initiated by the ENT association, but by the government also. For last so many weeks, the government, they were doing all these webinars for each and every Sunday to educate all the general physicians and physicians regarding the misuse of the steroids. So maybe these are all multifactorial things. So we are having less number of cases in West Bengal.
Possible.
I agree, actually.
Just Dwaipayan.
Yeah.
Yeah. Can you hear me?
Yes.
Yes. Do you have some idea whether this industrial oxygen and humidifiers are having some role in Mucor?
Can I?
See, Shweta, actually, I have mentioned few of the controversies. One of these is this oxygen. And see, you cannot actually segregate a specific type of oxygen. And coming to the point of your question, industrial oxygen is very pure one, around 98% purity. And we are having medical oxygen that is having around 88 to 90% purity. So there is no questions of impurity from the industrial oxygen. The number 2 is this humidifier. There are also lots of noise related with humidifier, but my personal thought is that see, in supervised manner, actually these oxygens were given in pre-COVID era in the ICU and everywhere, with steroid therapy, with uncontrolled diabetes and everything. The another point is that actually oxygen is coming inside the humidifier. There is bubbling of the water, and then the oxygen will go to the nose or the mouth. And usually fungus will not grow in a bubbling water. It usually grow in a stagnant water. So I think maybe this point is exaggerated. This is my thought.
Can I add something? Yeah. There is a paper has already come out in the Journal of Infectious Diseases. They have done an extensive study of all the Indian across India, and they have debunked the industrial oxygen already. They haven't grown any. Of the humidifier water, only one Trichurapalli humidifier has grown a colony of Aspergillus, not even Mucor, and all the other samplings were clear. So both the industrial oxygen mask and the contaminated humidifier water in oxygen has been debunked. So the focus again is back on the uncontrolled diabetic, uncontrolled steroid, and other immunosuppressive drugs.
I think
No,
there's an epidemiological
I
study.
just,
Just a minute.
There's a
Dwaipayan,
multi-center
commenter,
epidemiological study which
commenter
has shown.
asked one question to the panelists, that for how many days amphotericin B to be continued?
yeah,
Practical, not as
Diptanshu,
protocol.
I am having all these questions. I will ask. Let complete this issue. Oh, I just want to put one of my thoughts because that is not discussed here, or that is not discussed in all the platforms. Can it be a cause of this surge related with oxygen? I am not talking about the industrial oxygen. I am not talking about the humidifier. See, the modes of transmission, there are three modes of transmission. One is inhalation, another is ingestion, and another is traumatic inoculation. Now, in the second wave, we are having large number of patients across India in a specific point of time, and many of the patients were not actually getting chance to admit anywhere. So they were treated in home by teleconsultation. So only two modalities of treatment were there. One is if desaturation, start oxygen and steroid. Now, in our day-to-day practice and in our training period, we are actually seeing all the patients, they are getting oxygen in a supervised manner. So it is usual for all of us that the oxygen should come through one humidifier, because dry oxygen may cause injury to the mucosa. So that is known facts for everyone. But if in the periphery, in the interior part of the districts, if some people, they can arrange oxygen, may not arrange this humidifier, and in an unsupervised manner, there is a possibility that the patients in the interior part, they are getting all those dry oxygens that can also damage the nasal mucosa and may cause the derangement of the innate immunity. And at this damaged mucosa, the mucorals can engage and germinate to form hyphae. So I think this is one possibility in my thought. You can take this.
I think the epidemiological study that was done across India by the mycologists has shown that the risk factors that have been definited, one is hyperglycemia and one is indiscriminate use of steroids. But yes, it's a thought. I think it's the epidemiologist who's going to give us the answer, and maybe what you're saying may be correct. So at the moment, there is no evidence as such, but it's a thought, and I think the epidemiologists and public health people have to come forward and find out. Otherwise, we are all a part of history now.
But the message should be clear, even in the interior part also. Even at the time of teleconsultation, if the patient is having oxygen, and we should at least ask that whether there is a humidifier fitted with the oxygen cylinder or not.
Perfect. Perfect.
Okay.
Next question.
Next question, as every minute is important, can we start amphotericin B based on the clinical and radiological signs before we get the confirmatory report of Mucor or KOH fungal stain? And how long we should continue amphotericin? Should it be for a definite duration of time, or should it be a parameter based? How to follow up the patients after surgery?
I think this has been discussed.
Yeah,
this has been discussed, and we all agreed that if clinical judgment and radiological features and nasal endoscopic features suggest this is a mucor, then we will be quite confident to start amphotericin B pending further reports like a histopathology report. And we also have said one thing, because you are going to get more and more mucor now, we have to sensitize our pathologists and microbiologists that these tests have to be done as on war front. Absolutely, the report has to come as soon as possible. So this is the answer to the first question. And regarding the answer to the second question, I think again, I am just summarizing because it was discussed in the panel. There is no fixed protocol, universally agreed protocol globally to say how long, but yes, parameter based. Number one is clinical improvement, endoscopic surveillance. Number two, we have discussed that. Number two is radiological surveillance of repeat MRI. And also there are papers to say that there are some centers who are following a negative biopsy, showing healthy tissue without fungal infection in the operated cavity if it has been operated. So these are the features, and obviously glycemic control. If the glycemic control is fully achieved, a negative biopsy plasma, I mean, that's not 100%. MRI definitely, and signs of clinical and nasal endoscopic improvement, and improvement seen by the ophthalmologist on retinoscopy and on fundoscopy and other things who has a viable eye. So these are the things will dictate, but literature is saying that from any time between 2 to 6 weeks, it's so much variable. Any other comment by our panelist? Yeah.
Absolutely.
Practically, I think it's
On-
how deep your pocket is as well. And I think when one of the things that have been coming to my mind is, why don't we sort of make a universal thing of 2 weeks short sharp amphotericin B, so we conserve a little bit of amphotericin B, and then go on to posaconazole for the early cases where we are satisfied with the debridement therapy.
This has been clearly mentioned in some of the recommendations. That if there is an early case, 2 weeks, exactly what you said, 2 weeks of IV amphotericin followed by oral posaconazole for 6 weeks to 6 months, depending on the surveillance and endoscopic finding and MRI.
I think it
No,
was
triage is
mentioned in
required.
the
PM
AIMS
consideration of
recommendation.
medical mycology and that
Absolutely.
global guidelines.
So there is another question: is it possible to affect orbit without affecting nose? If so, how? And is there any role of local amphotericin? And this actually, I want to put 2 or 3 other questions related with this. That can we give this amphotericin with the Merocell packing or through nasal douching?
Anyone will take, or
I think
yeah,
the
yeah.
first thing that is important to understand here is, the first thing is surgical debridement is the one and most important thing that has to be done. All this amphotericin B injection is in adjunct, or packing is in adjunct. It should not replace the immediate surgical debridement. Regarding the packing of the cavity, operated cavity with Merocell, with amphotericin soap, or whatever, it's individual choice. People put gel. So long as you're inspecting and finding there is no recurrence, I think that's fine. As far as injection into the orbit is concerned, I think it's not our take. I think it's the take of the ophthalmologists who are on board, who can decide whether they're going to inject amphotericin B or not.
But it does work. There are papers to say that if the eye is not, even if the vision is lost, you can save exenteration by doing an retrobulbar, and sometimes the vision will also improve if you catch them in early stage.
I think this is
So,
such a
I just-
medico-legally prone area that I think an ophthalmologist on board has to concur and decide on the treatment. Otherwise, we'll be in a soup.
But they are giving, sir. They are giving intraorbital.
That's what I'm saying. There is evidence for
And it is
that.
very easy. After reconstitution, you have to take 0.7 and of reconstituted solution and 0.1 ml of that normal saline. Then again reconstitute it within the syringe and give intraorbital.
But one question of us doing nasal douche with amphotericin, because in our country, commercially available amphotericin douche is not available. So you have to again make a solution, and you can, but there are evidence in the literature that you can add to your armamentarium.
I have received few of the papers related with wash with specific concentration of pure hypochlorous acid, and this is very cheap and effective with the mucors. Actually, I have received this message from one of my very close doctor in UK. After seeing all these reports in the BBC, she mailed that maybe this is a cheaper option for the Indian people, because many of the patients may not afford this high cost amphotericin B. So any comment?
Hypochlorous acid.
Yeah.
Okay,
I
we
have
can try it.
no knowledge on that.
So I
I have no
also don't
knowledge.
have any knowledge. So most
Send us the
likely
paper.
we will
Send us the
have
paper.
one discussion later on, or maybe incorporated with the UK consultants, because they are having all this experience of using all these things. So another question, what about, yeah.
We have far more experience in Mucor than UK ever will.
So if this is one solution and a cheaper solution,
Absolutely.
then we
Absolutely.
can take it in a
Absolutely.
scientific manner. So
Absolutely.
last
Next
question,
question.
what about surgery in patients who are COVID positive? I think
This
we
has
have
been
covered.
discussed.
Yes.
So most likely I have completed all the questions. Dr. Chiranjeev Das from Kuchbihar asked that right now mucormycosis is a notifiable disease. So is there any obstruction for starting amphotericin B before proving it? This is a very valid question.
You can't.
But Arjun, what we have learned from our administrator, that if you will not notify, then you will not get liposomal amphotericin B from center. So if you have any suspicion and with MRI, if you think that it may come, there is a form. We have every day we are notifying that there is a form. When it comes, it's a fungal like KOH 10. You can notify them, but you need not to.
I'm talking about KOH 10 only. I'm talking about KOH 10.
But the confirmatory of confirmatory investigation is the biopsy. No, if you wait for the biopsy,
Understood.
then
No,
it is
no,
too
no,
late.
no. We are asking on KOH 10 only, or we are not really getting any. I mean, there are. I am told that the production have been ramped up. I sent some tweets to the pharmaceuticals, and by this week, probably the supply will improve. But let's see.
No, but this is a catch-22 situation, because you really can't wait for the patient to lose his vision, so you have to operate. I think it's a situation that when it comes, you notify. Ultimately, the government is to notify, and you'll have to do that. Previous patients amphotericin, you start in this fellow, and then finally you get the amphotericin on the name of this patient. That's the only way you could work around, because you can't work around red tapeism and treat
absolutely.
the patient.
I have an average of 48 hours delay before my patients get amphotericin B. So we start them on oral posaconazole, and when they get amphotericin B, we start them on amphotericin B. What can you do?
Is post-COVID invasive aspergillosis also notifiable? I think not.
No.
So with this, I want to hand over the session to our president, Dr. Shubhajit Banerjee. And thank you once again to the AY West Bengal Executive Committee for timely taking the decision and to host this meeting. And I think this will be beneficial for all our members across the state. Dr. Shubhajit Banerjee, please.
Thank you, Dwaipayan. I just have to give a vote of thanks. I thank our speaker, Dr. Dwaipayan Mukherjee, and Dr. Snehasis Barman, and our moderator, Dr. Professor Amitabha Roychoudhury, and all our panelists for this very interactive session. Thanking all the ENT colleagues who have watched this program in spite of their busy schedule. I thank Mr. Manoj Joshi, Mr. Manoj Dey, and Mrs. Jona Basu of SANOFI for standing with us by extending their technical support. Thanking you all. I just request Mr. Joshi to say a few words.
Thank you, sir. I will just take 1 minute. It has been immersing around 2 hours discussion. So I do not wish to miss out an opportunity to thank eminent panelist clinicians. Thank you, Dr. Amitabha Roychoudhury, for moderating the session very well. Dr. Ananda Bose, sir, Dr. Dwaipayan Mukherjee, sir, Dr. Shubhajit Banerjee, sir, Dr. Barman, sir, and Dr. Diptanshu Mukherjee, sir, and Dr. Debabrata. In fact, sir, I must say that our partnership with AY West Bengal has been strengthened under
Arjun Dasgupta.
So I once again wish to extend sincere thanks to all the eminent clinicians who have joined this meeting, scientific event all the participants despite their personal commitments and while managing possibly the patient's queries over telecalls and by treating them. And I also take this opportunity to once again thank the doctors for showing the interest in guiding all the participants on the latest topics, whether it is allergy or black fungus. Sir, I assure you on behalf of my colleagues and SANOFI that we will continue to put our best efforts by ensuring that we continue to partner with you for scientific events like this, which will ultimately benefit the clinicians to take the informed decision uh, with an endeavor of treating the patients, treating the ailing patients of the India of various indications. So thank you so much, sir. Stay safe, stay healthy. Thank you.
Right, West Bengal, and thank you, Sanofi. I think it was a wonderful evening. Stay safe and wish you good health.
So, right now I will request each and everybody to say a closing remark. Dr. Arjun Dasgupta.
Are we still live? Are we still live?
Yeah.
কবে যে আবার দেখা হবে সবার সাথে কে জানে I really want to meet you guys in person, but anyway, at least এভাবে চলুক, and thank you everybody, thank you Sanofi for a fantastic session. Enjoy.
Dr. Ananda Bose.
I already said thank you AOI West Bengal for allowing us to be a part of this session, and thank you Sanofi for partnering with AOI West Bengal. And I think it was a wonderful session, and meeting all you guys made me feel really, alive. Thank you.
Dr. Roychoudhury.
Thank you again, AOI West Bengal, for nominating me for conducting this panel, which I have learned so much from our learned panelists. Just I want to give give out this message to all the attendees that this webinar should serve as a sensitization drive to all the colleagues that we know, especially general physician, because I have seen patients getting earlier 2 years ago, 3 years ago, being treated for sinusitis, because Mucor was not a very common disease and was being treated for sinusitis, and I have seen ophthalmologists treating with IV antibiotic, IV steroid, thinking it's neuritis and all those things. So at least we should sensitize that this is an important thing, that even if you do not have resources to do a diagnostic endoscopy and do a fungal smear at your own standalone clinic in one corner of the state, please do send the patient to the necessary, at least make a phone call to whoever you know to send it to the medical college or private or whatever setup. So at least we can save the patient, because every hour is important. We keep on saying that. Thank you very much, AOI West Bengal, for doing this webinar at this just hour to sensitize all our members. Thank you.
Dr. Debabrata.
Thank you once again, Sanofi, AOIWB, for giving me the opportunity to share the learned panelists as a learned with the all learned panelists. And it's the need of the hour, this Mucor. And as we all know, COVID is an unknown disease, but Mucor is a known and preventable disease to us. So we should all stay strong enough to fight with this Mucor. That's all.
Dr. Diptanshu Mukherjee.
Thank you, AOI. Thank you, Sanofi, and thank you, my beloved president, for allowing me in this panel with our sir like Amitabha sir, Ananda sir, and famous person like Arjun Da. I am very much privileged to be in this panel. Thank you.
Our president, sir.
Secretary.
I again thank you all for this very good and interactive session. All of us have definitely learned a lot from you all, the panelists, and I think we will be prepared in future for treating these type of mycosis like that. Thank you very much again. And,
our secretary.
Hope to meet you soon.
Yeah, Dr. Snehasis Barman.
I want to thank all the participants who have joined us and stayed connected with us, and hope they have enjoyed the academic session. And I want to thank all the speakers for sharing their knowledge, and also I thank Sanofi for supporting the drive of AY West Bengal. We will continue our effort to spread awareness, not only among our members, and we will continue our efforts to spread awareness among the people also, patients also. So stay safe, stay healthy. Good night to all.
So with
Thank you.
this, we conclude this session. Thank you and good night, all of you.
Thank you.